So, good afternoon, everyone. Today we are going to discuss how to approach a case of temporal arthritis, or another name is giant cell arthritis or GCA, which is very important case actually. In E&E or AMU or same-day emergency care unit, or even in primary care if you are going to work as GP. How to recognize and approach a case of giant cell arthritis or temporal arthritis. Actually, as a medical rule, you have to bear in your mind this medical rule. You have to exclude the worst until otherwise is proved. So in the case of chest pain, for example, you have to exclude and think about PE, ACS, aortic dissection, pneumothorax, which are the most serious symptoms or the most serious diagnosis of chest pain. In the case of headache, for example, you have to think firstly and rule out or to exclude the most serious life-threatening condition like intracerebral hemorrhage, subarachnoid hemorrhage, and temporal arthritis, which is a vision-threatening, condition. So always bear in your mind to rule out the worst until otherwise is proved. So temporal arthritis or giant cell arthritis or temporal arthritis is a vision or eyesight threatening condition. So if it is not diagnosed and not given the treatment properly in the proper time, it may lead to visual loss. That's why you have to decrease your threshold for a diagnosis of giant cell arthritis. So giant cell arthritis is a systemic vasculitis, and it affects, the large and medium-sized vessels, especially the extracranial branches of the carotid artery. As we mentioned, temporal arthritis is a medical emergency which requires prompt treatment and action as soon as possible to save vision, because it may lead to and may be complicated by visual loss. Temporal arthritis is common more in women with age more than 50 years old, but doesn't mean that it doesn't come with other, sex. It can come with men as well and middle-aged men, but it's more common in female more than 50 years old, and most commonly it's associated with polymyalgia rheumatica patient. 50% of the patient of polymyalgia rheumatica may present with a giant cell arthritis. What is the etiology of GCA? The etiology could be multifactorial. There is no specific cause actually or identified cause of giant cell arthritis, but it is thought to be autoimmune in nature, or maybe environmental and or genetic predisposition could be a culprit as well. But overall, it is a kind of vasculitis, and vasculitis is an autoimmune disease because of autoantibodies. So it is characterized by granulomatous inflammation of the medium or large blood vessels, arteries. As we mentioned, it is extracranial carotid branches, especially the temporal, branches and ophthalmic artery are most common included in such condition. What are the risk factors for giant cell arthritis or temporal arthritis? As we mentioned before, the age is very important. So more than 50 years old are most common, age group which are affected by such condition. Female sex, but doesn't, rule out male sex can be affected as well, but it's more common in female patients. And also it's highly associated with polymyalgia rheumatica patient. Approximately 50% of patients with temporal arthritis have polymyalgia rheumatica. That's why in your history, you have to ask about symptoms of polymyalgia rheumatica and history of polymyalgia rheumatica, PMR, including frozen shoulder, back pain, chest pain, difficulty of moving, especially in the morning, stiffness in the morning. Clinical feature of temporal arthritis. Number one, the history. The history, it's very important to have, of course, the pathognomic symptom of a case of temporal arthritis is headache. And the character of the headache of temporal arthritis is unilateral headache and subacute in nature. Subacute means that it started gradually within a couple of weeks and getting worse or on and off. So, but of course, general headache doesn't rule out temporal arthritis. So in most of the cases, it is unilateral headache and subacute started within a couple of weeks, coming on and off or getting worse with time. Tongue and jaw claudication. This is one of the pathognomic features actually of temporal arthritis as well. You'll find the patient has claudication of jaw and tongue and during talking or showing, and this is because of the ischemia of the masseter muscle. Scalp tenderness. This is red flag actually in a case of headache. Any patient coming with lateral headache and scalp tenderness, the first thing to think about is temporal arthritis. And this scalp tenderness will be by touching the scalp of the patient, or when he's getting to the bed and touching the pillow, he will find that he has tenderness of the side of the scalp. Painless, complete or partial loss of vision in one or both eyes. Of course, this is one of the life-threatening, condition, or not life-threatening, it's sight-threatening condition. Now, if there's any visual disturbance, including partial loss of vision, complete loss of vision, you have to act at once because this patient is at high risk of permanent irreversible loss of vision. Diplopia also is one of the manifestation or clinical picture or in the history of the patient with temporal arthritis. Other important areas to cover in the history also, constitutional symptoms. Constitutional symptoms include fatigue, malaise, fever, weight loss, anorexia, and depression, which are manifestation of polymyalgia rheumatica actually, which is highly associated with giant cell arthritis. In the past medical history, you have to ask about history of PMR, polymyalgia rheumatica. As we mentioned before, 50% of temporal arthritis patients are associated with PMR. So constitutional symptoms are very important, including malaise, fatigue, headache, loss of weight, and of course, muscle pain, shoulder pain, frozen shoulder, and morning stiffness, which are manifestation of PMR. Clinical examination. In clinical examination, you'll find palpation, auscultation, fundoscopy, and the blood pressure. 4 elements or 4 points in clinical examination are very important in a case of temporal arthritis. In palpation of the temple, of the side of the headache, you'll find that there is tenderness. And there is reduced or absent temporal artery pulse. So there is 2 signs. Tenderness on the temple and absent or reduced temporal artery pulse. On auscultation, you have to auscultate the axillary, brachial, and the carotid artery for Berry. The presence of Berry is highly suggesting temporal arthritis, but the absence of Berry doesn't rule it out. Blood pressure, you can find asymmetrical blood pressure in both sides of arms, but its absence doesn't rule it out. Its presence highly suggestive for the diagnosis. Fundoscopy is very important as it may reveal that you have edema with blurred optic disc. This is highly suggestive of the diagnosis. That's why in a patient with temporal arthritis, you have to refer the patient urgently to ophthalmologist in the case of any visual disturbance there. So clinical feature again, palpation, auscultation, blood pressure, and fundoscopy. 4 elements. This is a brief summary. Yeah.
How bad should the tenderness be for you to suspect it?
It's different from one patient to the other according to the severity of temporal arthritis. It could be mild, moderate, or severe, or even the absence of tenderness doesn't rule out temporal arthritis. We are talking about the typical manifestation of giant cell arthritis, but absence of some of these features doesn't rule out temporal arthritis. Can come with a typical manifestation most of the time. This is a summary of the clinical picture of history and the clinical picture of GCA. history again. We can find headache, which is very important. There is no patient with tumor arthritis without headache, actually, So if there is no headache, you don't have to think about tumor arthritis. Headache is the pathognomic, a symptom of the patient with GCA. And the headache will be unilateral most of the time and subacute within a couple of weeks, on and off, or getting worse. Number 2 is tongue and jaw claudication. This is because of masseter muscle affection, scalp pain and tenderness. And the patient himself will tell you that there is a pain on the side when I'm getting to the sleep or touching a pillow or touching my temple. A visual disturbance, and the visual disturbance could be in the form of double vision, diminution of vision, blurred vision, partial loss of vision, or complete loss of vision. And if there is any visual disturbance at all, this is a red flag sign that you have to refer the patient directly for both rheumatology and ophthalmology to do fundoscopy to check for the optic disc. Systemic fissures, as we mentioned, like fever, loss of weight, malaise, fatigue, and of course, muscle pain, stiffness, which are manifestation of polymyalgia rheumatica, PMR. Clinical examination, as we mentioned, including 4 points: palpation for tenderness, auscultation for puree, and auscultation will be on the axillary and carotid artery. Asymmetrical blood pressure measurement in both arms, and fundoscopy, which is very important examination, especially in cases of visual disturbance, which will reveal pale disc with pale peripheral disc, border, which is edema, disc edema. Yeah. Okay. Investigations. What investigation of each choice in a case of suspected temporal arthritis? Number 1 is full blood count. So basic investigation. We are going to start with basic investigation, like every patient, FPC, UNEs, LFTs, and inflammatory markers. In full blood count, you can find normocytic normochromic anemia, especially in cases of PMR. But absence of anemia doesn't rule it out. Yeah. CRP and ESAR. CRP will be high in a case of PMR, but normal CRP doesn't rule out again GCA. Why? Because CRP can take like a couple of days, 48 hours to raise up. The more sensitive inflammatory marker in the case of polymyalgia rheumatica, in the case of temporal arthritis, is ESR. ESR will increase, abruptly and suddenly within short time. And the presence of ESR more than 50 is highly suggestive of the disease. LFTs, you can find that ALP and transaminase might be slightly high, but again, normal LFTs doesn't rule out rheumatoid arthritis. But increased or slightly high LFTs may support the diagnosis of GCA. Imaging. Non-invasive imaging, including temporal artery ultrasound, is the most usual imaging or scan or available scan for a case of GCA, and it will reveal thickening of the wall of the affected blood vessels, a phenomenon known as halo sign. As you see here in halo sign, you will find this is the red color is the blood flow, and this is the wall of the vessels which will be thickened here. All right. And this is very approachable and accessible, available non-invasive scan, which can highly support the diagnosis or even can confirm the diagnosis with other clinical fissures and lab fissures as well. Temporal artery biopsy. Temporal artery biopsy actually is the definitive investigation of a choice to confirm a diagnosis of temporal arthritis. And it will reveal that there is multinucleated giant cells in the wall of the arteries. But honestly and practically, it's not usually used actually for many reasons. Number 1, it's an invasive procedure. Number 2, it can give false negative results because you might have skipped, lesion on the artery. You might take a biopsy from the artery, and this side of the our artery is not affected. As you know, it's patchy thickening and patchy vasculitis. So not the whole artery is included or involved. That's why we are not using actually tubular artery biopsy usually or practically in our clinical field. We depend more on our history, clinical science, and lab or blood investigations results. Management of GCA. If you are highly suspecting GCA in terms of history, clinical science, and lab science, or sorry, and lab finding, what the treatment of choice? You have to urgently refer the patient to rheumatologist to be seen the same day. So same day referral to rheumatologist, because as we mentioned, it is eyesight threatening condition. That's why we have to refer the patient urgently to be seen by rheumatologist. Number two is to refer the patient urgently to ophthalmologist. But this should be in a case of visual disturbance. If it is associated with visual disturbance like visual reduction or blurred vision or partial loss of vision or complete loss of vision, at that time you have to refer the patient urgently within the same day to ophthalmologist to check the back of the eye or fundoscopy for any signs of papillary edema. Of course, the presence of papillary edema, in addition to characteristic headache and high inflammatory markers, I think this is enough to make a diagnosis and start the treatment plan at that time. Number three, for patients with mild visual symptoms, what does it mean mild visual symptoms? Like blurring of vision or diminution of vision. At that time, you have to start on prednisolone at once. And, the dose or stat dose of prednisolone between 60 and 100 milligram before referring the patient to rheumatologist. You don't have to wait for rheumatologist to see the patient or ophthalmologist to see the patient. You have to start steroid at once if you are highly suspect, diagnosed of GCA. And the dose will be 60 to 100 milligram stat. Then you can refer the patient. And later on, you can keep the patient on the dose of 40 to 60 milligram for a duration of 1 year, 12 months to 18 months. So this is the duration of steroid. What if the patient has visual loss, either partial visual loss or complete loss of vision? At that time, you have to start mesalbred, high dose of mesalbred, 500 to 1 gram IV for 3 subsequent days, in addition to referral to ophthalmologist and rheumatologist, of course. Yeah. So 2 referrals and 2 treatment. One referral is for rheumatology at the same day. 1 referral to ophthalmologist in the same day if there's any visual disturbance. If there is minor visual disturbance, we can start with prednisolone, 60 milligram or 100 milligram. If there is any visual severe visual disturbance or a partial or complete loss of vision, at that time we can start 500 to 1 gram intravenous mesalbred for 3 subsequent days. This is just, a brief or a concise algorithm of treatment or management or approach of a case of GCA. So again, as we mentioned, urgent referral to rheumatologist in the same day, urgent referral to ophthalmologist in the same day if there is any visual disturbance to check for any evidence of papillary edema. And start with a dose of prednisolone between 60 to 100 if there is minor visual disturbance. Start with a dose of 500 milligram or 1 gram of mesalbred if there is any partial or complete loss of vision. Again, starting prednisolone, yes, right. Starting prednisolone as soon as possible might preserve the eyesight of the patient, might keep his vision. And any hour delay of starting steroid may threaten the eyesight of the patient. That's why steroid is very important to be started as soon as possible after full history, full examination, and a blood investigation. If all of these are highly suggestive of GCA, you have to start a treatment at once in addition to your referrals. Ongoing management, it means that long-term management. Now you confirmed your diagnosis of GCA, and you are going to continue on treatment, for how long will be the treatment and what other consideration you have to bear in your mind. The recent guidelines suggest that if the patient has started in prednisolone oral, it has to be continued for 12 months to 18 months with tapering dose, of course. And this will be done by a rheumatologist, by the way. Can be to decrease the dose of 5 milligrams every week as a tapering dose to avoid, of course, adrenal insufficiency. Number 2 is to monitor the patient. What to monitor? After the patient should be seen after 2 to 8 weeks for the first 6 months regularly, to check for the improvement of the symptoms of the patient and also to check for other complications of a steroid, long-term steroid. We know that steroid in the long term can cause complications like weight gain, stretch marks, hypertension, hyperglycemia, and osteoporosis. Of course, you have to monitor the side effects and the complication of prednisolone in the long term. Prednisolone for 1 year, 1.5 years might have a lot of complications. That's why it should be monitored. You have to monitor glucose, CBG, and you have to monitor blood pressure of the patient. You have also to give PPI. Don't forget to give PPI for GIT upset. Also, you have to give prophylaxis for osteoporosis, especially in old patients, like zoledronic acid or aldoronate, because of risk of osteoporosis. Complication, what complication can be associated with GCA? If not treated properly in proper time, GCA can be complicated by irreversible loss of vision. It also can be complicated by aortic dissection, aortic aneurysm, and large artery stenosis in a case of, if it is including arteries like aortic artery or carotid artery. CVA can be one of the complications as well of temporal artery arteritis. Stroke and myocardial infarction are more common in the patient with temporal arteritis. So it's not only threatening the vision, it can threaten also the heart. It can be associated with CVA, it can be associated with MI as well. It's a kind of vasculitis of the major blood vessels and medium-sized blood vessels. And of course, don't forget about a complication of longer-term steroid, including hyperglycemia, hypertension, osteoporosis, GIT, upset, weight gain, stretch marks. All of these should be monitored carefully and regularly. Thank you all, and open discussion if anyone has any question at all. I tried to make it very concise, precise, and targeted to the point, not to push a lot of information, unneeded information in your stage or level. If anyone has any concern or question at all. Hallucinations.
Yeah, I was just wondering how you manage that.
Yes, steroid can be associated with many side effects. Hallucination and mood disturbance could be one of the side effects of steroid. But it's a matter of outweighing the risk versus the benefit, actually. Hallucination could be managed by referring to a psychiatrist. We cannot give anything, actually, and you cannot stop the treatment because of the importance of the treatment, Yeah, of course. 3 days, this is 3 days treatment in a case of partial or complete loss of vision, and followed by oral for total 12 to 18 months, yeah.
But the hallucinations typically not happen?
It can happen, sorry?
The hallucinations, do you expect them to start?
It can happen within the first dose, by the way.
Even when it's low dose and oral?
Yeah, okay. Could be, yeah. But low dose at the beginning is quite difficult, actually, but can happen because what's called tolerance. patients are different of tolerating a treatment. Actually, some patients can tolerate treatment very well. Some patients cannot tolerate treatment and can start to have serious side effects of the first dose of the treatment. Any treatment, you know, this is what called adaptation or tolerance, which is different from one patient to the other. Yeah, thank you all. I appreciate your presence today. I'll be grateful for your feedback, and let's keep on our teaching session. Thank you all.
Oh, yes.